Okay, next is Dr. Nicole Minnifield, who's assistant professor at Southwestern and one of our esteemed colleagues at the VA. And one of the obstacles that I think a lot of our colleagues in private practice are going to have to face is how do we practice within the realms of reimbursement. So not only generate clinically sound advice, but also one that can be compensated for. And one such area that's impacted non-invasive testing is the use of echocardiogram in an appropriate manner. And so this is an indirect case in which appropriateness will be directed. Dr. Minnifield?
I want to thank everyone who has weathered through this day and is still with us at the heading towards a conclusion. As Dr. Garcia mentioned, I wanted to touch a little bit upon appropriate use, particularly in the non-invasive realm, since that's where I am. All day we've heard a lot about all these exciting interventional cases, but today I'd like to highlight a typically bread and butter case where I'd say on a daily basis, on average, we get about 10 consults a day for the evaluation of murmurs, and probably 80% of the time, it's a waste of money. So I thought I would actually pick a case where it actually was useful. And with that being said, the importance of the use of echo in the evaluation of patient with suspected valvular heart disease and someone with a murmur, there is a role, in fact. And so as providers, what's important is for us to figure out when we do need to take the time to go ahead and increase our costs, which we do have to be mindful of, when an ultrasound would be indicated. So I'll start off with the case, a 57-year-old male with diabetes who was found to have a 3 out of 6 systolic ejection murmur, which was found on a preoperative evaluation. And for this reason, an echo was requested, which demonstrated this picture here. So just to orient the audience a little bit, this is a transthoracic image of the heart. And again, for orientation's sake, I'll point out this is the left atrium, mitral valve, left ventricle here, aortic valve, and up top the screen is the right ventricle. And besides the abnormally dilated left atrium that we see here, the other thing that stands out is this is a markedly thickened or hypertrophied left ventricle. More importantly, the degree of hypertrophy of the septum here seems to be a bit more than the rest of the myocardium, or particularly the posterior wall of the heart. This is another transthoracic image, an apical 5-chamber view of the heart. We have left ventricle here, mitral valve, aortic valve. This is the right ventricle and right atrium on this side of the screen here. And with the addition of color Doppler here within the left ventricular outflow tract, one can appreciate this area here where there is a flow acceleration or turbulence, which is indicative of some degree of obstruction within the left ventricular outflow tract. Also, I'd like to also point out for someone who has trained eyes, you can appreciate there is a little bit of motion of the mitral annulus towards this basal part of the septum here with resultant mitral regurgitation. This phenomenon is known as systolic anterior motion. And the combination of the asymmetric hypertrophy in addition with the systolic anterior motion, or SAM, and the mitral regurgitation raises the suspicion of the autosomal dominant disorder, hypertrophic cardiomyopathy. Before I move into clarify further information on hypertrophic cardiomyopathy, I'd like to just discuss a couple of order disorders or a couple of things in our differential as a cardiac sonographer, things we would have to consider in someone with a systolic ejection murmur on exam and the presence of outflow tract obstruction on the echo. So the first finding is something that is exceedingly rare in the fact that, I've been on staff almost 6 years now, and my N of 1 is a case here of actually the presence of a subaortic membrane in the LV outflow tract. This actually is a deep transgastric view of a transesophageal echo, and I think you can appreciate there is something that looks a little abnormal there, proximal to that aortic valve opening and closing. And if we add color Doppler there, again, you can appreciate the degree of flow acceleration or turbulence there within the LV outflow tract. And so again, this is the presence of a subaortic membrane in another patient who was also found to have a systolic ejection murmur on exam, for which they ultimately got an echo and then a transesophageal echo. The other far more common reason, we've heard a lot about aortic stenosis, and this is, again, another parasternal long axis view of the heart, where, again, we see a significant degree of hypertrophy of the left ventricle, and this is actually is a case of more moderate aortic stenosis. Short axis view at the level of aortic valve, again, just you can appreciate there is severe restriction of the aortic valve from opening. And then on this apical 5-chamber view, with the addition of color Doppler imaging, you can appreciate there's flow acceleration or turbulence more across the level of the valve, not so much in the LV outflow tract. And again, looking at aortic stenosis and hypertrophic cardiomyopathy, which are far more common seen in clinical practice compared to the subaortic membrane, I wanted to highlight some of the ultrasound similarities and differences between the two cases, since they have similar presentations. So on the left side of the screen is the continuous wave Doppler of our case of moderate aortic stenosis, and what you can appreciate is, there is a peak velocity of close to 3 meters per second. And on the right of the screen, the hypertrophic cardiomyopathy continuous wave Doppler also shows that high velocity, around close to 2.5 meters per second. Where the divergence between the two cases is again trying to identify where the level of obstruction is. And if you take the pulse wave Doppler now, which is a more definitive way of isolating the level of obstruction, and you put that Doppler signal within the LV outflow tract, you see a normal velocity of blood flow as the blood is exiting the heart. In comparison, on the right side of the screen, our hypertrophic cardiomyopathy patient, pulse wave Doppler demonstrates a peak gradient of close to 20 millimeters of mercury. Furthermore, now that we've established we have a case of hypertrophic cardiomyopathy, the question of whether or not you have the presence of obstruction or not. And there are cases where at rest or during resting conditions with the patient just lying still on the table, you have the findings of hypertrophic cardiomyopathy and you may or may not have obstruction. In this case, you see a resting gradient of about 16 millimeters of mercury, which, again, we do physiologic provocation, and we're somewhat limited in the echo lab of what we can do, but we can introduce the Valsalva maneuver, which will bring out, has the potential of bringing out a significant obstruction on that basis. And in our case, the gradient went from 16 to 30 with the addition of Valsalva maneuver. So just wanted to expound a little bit about hypertrophic cardiomyopathy. The clinical definition is a disease state characterized by unexplained left ventricular hypertrophy in the setting of a non-dilated ventricle, in the absence of another cardiac or systemic disease that itself is capable of producing that degree of hypertrophy in a given patient. When you see hypertrophy, you have to consider, first of all, is this physiologic hypertrophy in the setting of a well-trained athlete? And really the only way you'd be able to make that determination is if you gave that person a time where they're not going to be in training, and you would look for reversal of the hypertrophy. And you compare that with, obviously, longstanding hypertension and the effects that have on the ventricle with the pathologic left ventricular hypertrophy. And then finally, the other condition where we see a lot of hypertrophy is in the setting of infiltrative heart disease. So with hypertrophic cardiomyopathy, it's not just one size fits all, and there are some different variants that we have to consider. as in with our case, there is the asymmetric septal hypertrophs, which may or may not be associated with the presence of obstruction. As with our patient with obstruction, you see the phenomenon of systolic anterior motion of that mitral valve, which comes in contact with the septum, and you see resultant mitral regurgitation, which all later on play a role in the pathophysiologic disease process of those patients with hypertrophic cardiomyopathy. You can also have patients with the same degree of hypertrophy and no obstruction be apparent. The other thing to consider is you can have a pattern of concentric hypertrophy, and it may or may not also be associated with obstruction. And in the case of concentric hypertrophy, most of the obstruction occurs within the mid-cavity. This becomes important when we're talking about therapies or people who have symptoms and you're escalating your therapy to your invasive approaches. And then finally, we have our apical hypertrophs, which the site of the instruction is at the level of the apex. So for all comers or all patients with hypertrophic cardiomyopathy, about a third of your patients will actually present with signs suggestive of resting obstruction, and that's really defined by the presence of a gradient of more than 30 millimeters of mercury. You have those, as with our case, have a more dynamic obstruction or labile gradients with their pressures being less than 30 millimeters of mercury or less at rest, but with some sort of physiologic provocation, the gradient becomes higher or significant more than 30 with that provocation. And then finally, a third of patients will have the non-obstructive form and will live happy lives. Diagnosis for hypertrophic cardiomyopathy is conventionally made clinically and most of the time with just 2D echo ultrasound. And really, the presence of hypertrophy more than 1.5 centimeters in adults in the presence of a non-dilated chamber is enough to make the diagnosis. I do have to recognize the role for cardiac MRI, particularly if the echo is not conclusive, as with some of our patient population where just the limitations of the ultrasound makes it difficult to make a definitive diagnosis. And MRI is also very useful to really define the apex for our apical hypertrophs. I don't have any MRI pictures, but they're just beautiful. And finally, there's a role for MRI really in the stratification and underlying or helping to define the individual's risk for sudden cardiac death. Just a word about genetic testing. As mentioned, this is an autosomal dominant disorder, and genetic testing isn't often useful in the primary patient, but the role is really more so there to help identify affected family members in patients with known hypertrophic cardiomyopathy. Clinical course is quite variable, ranging from patients being asymptomatic all the way again to the risk of sudden cardiac death. And this particularly what we're concerned about in our competitive athletes, as well as a range of symptoms from angina, shortness of breath, heart failure, and again, atrial fibrillation, which we heard a lot about earlier today. Medical management, I'll conclude my thoughts with touching a little bit on the management of hypertrophic cardiomyopathy. First line of therapy is really going to be your beta blockers, and again, these are people with symptoms. Those who are asymptomatic, you just watch them. But once we have the development of symptoms, we'll initiate beta blockers, calcium channel blockers, verapamil or diltiazem. And then finally, if we still have symptoms, despite the beta blockers and calcium channel blockers, you can add disopyramide. For your medically refractory population, and again, the person with the right anatomical variant of hypertrophic cardiomyopathy, there are your invasive strategies, first being the preferred surgical myectomy. Again, you have to have the right anatomic location to derive the benefit. For those who have prohibitive surgical risk, the non-invasive forms of alcohol septoablation is becoming increasingly more utilized, as with all our other interventional strategies. More work is being taken away from the surgeons. And then finally, we have RV pacing in those who are older with prohibitive surgical and percutaneous risk. And then I just, out of the scope of our discussion today, but just also want to mention that there is a complex algorithm for defining the need for implantable cardiodefibrillators to reduce your risk of sudden cardiac death. And that's all I have. Thank you.